would ultimately, all the patient will present as a proptosis. And what is proptosis is, it is a forward movement of the globe in relation to the skull, measured by protrusion of the apex of the cornea in front of the outer orbital ring. Normally, the protrusion would be around 14 to 21 millimeter, and an average being 16 millimeter in Indian eyes. If it is abnormal, that is greater than 20 millimeter, or the difference between the two eyes is greater than 2 millimeter, then it is considered as a proptosis, which can be axial proptosis when the eye is displayed straight outward along the anteroposterior orbital axis, especially seen in cases like thyroid ophthalmopathy or any lesion which is intracorneal, like in this case. Or it could be abaxial when the eye is pushed forward and also displays off the central axis. Some of the extracorneal tumors like pleomorphic adenoma or adenoid cystic carcinoma will have this kind of a picture. Sometimes we have a pseudoproptosis, especially seen in cases with unilateral high myopia, lid retraction and unilateral enophthalmos, like the respective cases. Now, in clinical workup of a proptosis case, we should stress upon age, duration, onset, progression, any specific association with the vision loss, diplopia, pain, swelling, any systemic illness along with that, and the past history of any thyroid disease, trauma or malignancy. Now, coming on to the examination by itself, so first and foremost, we should do a thorough inspection of these patients, especially look for the subtle facial asymmetry, like this one of the patients with the dermoid cyst, as you can see here. There is a facial asymmetry on the right side where you can see there is a dermoid cyst on a CT scan. Then, in patients with axial proptosis, you will have this bilateral protrusion of the eyes along with the lateral flare, a classical case of thyroid, and abaxial proptosis like in this adenoid cystic carcinoma patient. Then look for the periorbital fullness as per the lesion. But then we have to look for the skin changes, which can be especially seen in vascular malformation like this reddish discoloration of the skin surrounding area, or xanthogranuloma with a bilateral lid swelling. Palpebral aperture size changes could be there in sebaceous gland carcinoma or some of the lymphomatous proliferating tumors. Now, this kind of a picture with lid retraction and a lateral flare is quite diagnostic of a thyroid ophthalmopathy. Then, to look for the position of the globe, we have these two classical views, the Nafziger's view, where you look on the patient from behind, and the worm's eye view, in which you look from the patient down. Now, coming on to the exophthalmometry or the poprometry, it measures the anteroposterior plane, the distance between the apex of the cornea and a bony point usually taken to the deepest portion of the lateral orbital margin, with the eye looking straight ahead. It can be of three types: absolute, wherein you compare with the known normality; relative, where the comparison with the relative proptosis of the two eyes is done; or a comparative, where it compares the exophthalmos of eye at different times. Now, this is what we generally use, the Herter's exophthalmometer, and we first and foremost should always mention the bar reading, because that is one which can, falsely give the readings. And abaxial proptosis can also be documented with the help of two rulers. So, this is another instrument, Lude's exophthalmometer. This is a transparent plastic millimeter ruler. The notch at the end, this confirms that we are keeping it at the angle of the lateral orbital ring, and the scale reading varies from 0 to 40 millimeters. The parallax is minimized using scale on both sides of the rod. Now, further, the tumor surface has to be felt properly, especially for any nodular surface, ill-defined areas, ulceration, destruction of surrounding structure has to be noted, especially in cases of malignancy and necrotizing lesion. We have to look the conjunctival fornices in detail, like in this case with the lymphangioma or keratoconus fistula, where you can see the dilated vessels, or this is a typical salmon patch appearances in cases of lymphoma or in cases of cavernous sinus thrombosis. Now, patients with suspected vascular malformation has to be seen both before and after Valsalva. Okay, I'll show this video once. This is how we ask the patient. First and foremost, we document the lesion, then ask for a Valsalva maneuver, any kind of maneuver, and see after 30 seconds what is happening in this patient. There is an increase in the swelling in this area. So this is how a Valsalva maneuver can be done and look for vascular malformation. Of course, each of the patient we have to see the fundus carefully, especially to look for visible pulsation. Along with that, all the ocular examination like best corrected visual acuity, extraocular motility, anterior and posterior segment. Especially, you have to look for the optociliary shunts in cases of to rule out schwannoma versus a meningioma patients. Now, in palpation, we have to start from the orbital rim, relax the orbital septum, and feel with the finger deep inside. Look for the location, extent, border, fixity to the bone, tenderness, any surface, temperature indicating an inflammatory lesion, the consistency, surrounding bore, and the retroversion test. Auscultation is useful in few of the vascular lesions, and always document along with the old photographs of the patient. Now systemic examination has definitely a role, like this is the patient with plexiform neurofibroma. You can see these cafe alert spots. Also a patient with a neurofibromatosis along with optic nerve glioma. So you have to look for a systemic association in such kind of a patient. Now if the patient is presenting with bilateral proptosis and if he is an adult, look for these three causes importantly: the thyroid eye disease, the lymphoproliferative disease, or a bilateral cavernous sinus thrombosis accordingly. And in children with a bilateral proptosis, you should look for a leukemia, neuroblastoma, orbital cellulitis kind of a thing. If the patient is presenting with axial proptosis, most and foremost, it will be like a thyroid ophthalmopathy, either a meningioma if an old patient, optic nerve glioma if the patient is in first decade, or a cavernous hemangioma if it is in female in 30s or 40s. And non-axial proptosis, you should look for a lacrimal gland tumor, schwannoma, dermoids, mucocele, or a lymphoma. If the swelling is there from birth, then we have to look for meningocele, teratoma, hemangioma, hematoma, or encephalocele kind of a picture. In children's, I think ma'am has already covered the lesions in children, and in adult you have to look for thyroid eye disease, lacrimal gland tumor, again cavernous hemangioma, pseudotumor, varix, mucocele. Now this is the patient with a meningocele, as you can see in this patient. Then teratoma is one of the rare cases to be seen. This slide I have borrowed from Dr. Neelam Bushra, where you can see there is in this will have an ectodermal, mesodermal, or kind of endodermal elements along with the normal swelling. So, and in lymphangioma, as you can see that pediatric lymphangiomas, where you can see this multiple subtessions in the lesion, and this chocolate kind of the typical picture of a chocolate cyst, causing an acute presentation of the patients. Again, few patients with lymphangioma. Now RMS. Patients will present in first decade with a rapid unilateral proptosis with globe displacement, and CT scan will show irregular margins and often bony distortion. I think most of these are covered by Dr. Ruchi already. Again, in like leukemic deposits, granulocytic sarcoma and leukemia. And coming on to the lacrimal gland tumors, I briefly touch upon the clinical features of this. This will be like younger patient with painless proptosis, probably more than 1 year. And pain is sometimes seen in less than 10% of the patient, but if the pain is present, it goes more in favor of adenoid cystic carcinoma. This is the patient with recurrent pleomorphic adenoma following an incomplete removal. As you can see, there is a slight bony erosion. So, if the incomplete removal has been done, it can masquerade a picture like an adenoid cystic. Now, coming on to adenoid cystic itself, these will be the patient with proptosis with less than 1 year, and pain will be almost seen in 80% of the patient, along with paresthesia, along with bony destruction on a CT scan. Now, cavernous hemangioma, as we all know, these will be well localized tumor, mostly intraconal with an axial proptosis like this. Sometimes they will be on inferior orbit. Schwannoma again is quite well demarcated. On USG it will have a round configuration, and these can be easily excised in toto. Lymphoma will be the one, either a primary or a secondary metastatic. These kind of orbital tumors can also be there. And almost in adults, metastatic orbital tumors will be around the globe and not inside there like in pediatric patients. So metastasis metastasis will be from the either breast, lung and prostate cancer, and sometimes in melanoma. And almost 10 to 15% of this patient will have an unknown primary, so we have to do a PET CT in such kind of patients. That is all, I think. This is how a clinical evaluation of an orbital tumor should go. Thank you.